So moving on to the patient trigger ventilation. So the patient can initiate or trigger the ventilator breaths. So you need a sensor. If you do not have a sensor or a mechanism to detect the inspiratory effort of the neonate, even though whatever mode you are setting in the ventilator, it will not act. So you definitely need a sensor. So how do we go about it? Okay. So the triggering, it can be by a thoracic impedance, or it can be by a thoracic impedance is something like which the ECG picks up the respiratory rate, very similar to that. It can be a special Grasby capsule. So all the apnea monitors uses this. So this can be there. Or it can be a specialized flow sensor, which can be either a variable orifice flow sensor or a hot wire anemometer, or sometimes it can be pressure transducer. But having said that, majority of the time, we use hot wire anemometer. So it senses the difference in the temperature when the baby is trying to breathe. The temperature difference is being sensed, and that initiates the breathing. It recognizes that the baby is going in for inspiratory phase and starts the breathing. Though thoracic impedance and other Grasby capsules are very simple, the main disadvantage is they cannot measure the tidal volume. We will learn in subsequent sessions how important it is to measure tidal volume, because in your hybrid mode, you will be using tidal volume. So majority of the time, we use hot wire anemometer. There are newer sensors like NAVA also, which can trigger and sense in a very accurate manner. So as I said, they are hot wire anemometer. They can be used. What is the benefit of triggering? It gives a lot of comfort to the baby because it kind of inspiratory asynchrony can be eliminated, and thereby improving gas exchange, thereby reducing work of breathing and lung damage, and thereby reducing the fighting of baby and causes decreased risk of IV hits. And you will be using less sedation, so you will be able to wean from the ventilator very fast. So what is the problem with the trigger? Sometimes a non-respiratory stimulation can cause a trigger. Major problem is the auto-cycling or auto-triggering, which happens majority of the time due to humidification. There can be water droplets in the inspiratory limb, which triggers. So sometimes the ventilatory rate can go even up to 100 if there is an auto-triggering. You need to identify that and fix it up. Sometimes whenever there is an ET leak, you have put a smaller size tube that can also simulate as if there is a difference in the flow, and that can get sensed. Sometimes it can fail to stop. So depending on the patient trigger ventilation, you have SIMV, which is synchronized intermittent mandatory ventilation, assist control or SIPPV, which is synchronized intermittent positive pressure ventilation, PSV, which is pressure support ventilation. Sometimes you can combine SIMV with PSV. So what is SIMV? Tell very simply, you have a set rate, set respiratory rate from the ventilator. The ventilator supports only the set rate. However, it allows the baby to take the breathing in between. So it does not prevent the baby from breathing. If the baby wants to take some breathing over and above that of whatever has been set as the respiratory rate, it allows it, but only the set breath rate are supported by the ventilator. So if the baby is breathing more, some of the breaths will go unsupported. So if you see here, there is this is a baby spontaneous breathing. So this gets triggered. So the trigger mechanism is activated, and the ventilator also gives a breath. Whereas here the baby is trying to inspire, whereas the machine is still in expiration. So sometimes SIMV can have an occasional inspiratory asynchrony, but expiratory asynchrony is not prevented, because here the baby is in going for an expiration, whereas the machine is still in the inspiratory phase, because we understood this as SIMV is time cycle. Okay? when I say it is time cycle, the mission changes from inspiration to expiration only after the set PA reaches. So this is the disadvantage of SIMV. So there is what is known as there is a trigger window period. Whenever the spontaneous breath falls in the trigger window period, then the breaths will be supported. If the baby is not breathing at all during this trigger window period, then the machine gives a breath on its own. So it is equally paced. For example, here the set rate is 60 per minute. Per 1 second, there should be the cycle should happen per second. So for 1 second, there should be an inspiratory and expiratory phase happening. So the machine will try to have a trigger window set. So here, this is an SIMV breath. So even though on your ventilator screen, you will be seeing only these positive deflections, because these negative deflections are the spontaneous effort, thereby increasing the transpulmonary pressure whenever there is a synchronization happening, thereby reducing the work of breathing. You will be seeing on your screen only some of this and few of the spontaneous efforts like this. You will not be seeing a negative deflection on your ventilator. So this is the flow graph, the same. And you can see here that there is a variable tidal volume depending on whether there is a spontaneous breath or whether it is a supported breath. So I repeat again, SIMV supports only the set rate, whatever you have set. Say, for example, you have set a rate of 40, baby is breathing at a rate of 60. The machine will support around 40 breaths, provided that they are falling under the trigger window. And remaining 20, the baby will take breaths, but it will not be supported by the machine. So we know that, the advantages is inspiratory, synchrony is an advantage. You can have set number of inflation breaths. You can control you can have a control over how many breaths you want to support. Whereas disadvantages, spontaneous breaths is not supported, especially in an acute stage when the baby is having CO2 retention. If you have set a lower rate, not very close to the rate which the baby is breathing, you will not be adequately supporting the baby, and there might be still increase in work of breathing. There could be uneven tidal volume. As you saw in the graph, some of the spontaneous breaths can have a lower tidal volume. That can cause sometimes atelectasis and atelectator injury. And sometimes, there could be some amount of asynchrony in inspiration and complete expiratory async. So here, the baby decides how much the baby needs to breathe, because the triggering mechanism allows the baby to take whatever the baby needs, and it will get synchronized by the ventilator. So moving on to assist control or SIPPV, the rates are not set, but it is decided by the baby as such. So say, for example, you have set a rate of 40, baby is breathing at the rate of 60. All the 60 breaths will be supported, provided you have set the trigger in such a way that it picks up all the baby's spontaneous effort. Remember, you have to know your missions. We will be dealing more in the hands-on session how to set the trigger. Generally, you want all the baby's breathing effort to be recognized by the ventilator and make a trigger. So you need to have a higher sensitivity, or you want all the breaths which the baby is taking to be supported as. In case if the baby is not breathing at all, as the name suggests, it will assist a baby's breath. If the baby is not breathing at all, it will go to the control mode and deliver at least the set rate. So here, provided your trigger, so there is a dotted line here, that is the trigger. So if the baby is, if the inspiratory flow or pressure trigger, whatever you have set, is reaching there, then it is being triggered and the machine gives a breath. So all the breaths above the trigger level are supported. So you are taking away all the inspiratory asynchrony here, unlike SIMV. So wherever the baby is in inspiratory phase, the machine also is in inspiratory phase 100% of the time. But sometimes there can be still expiratory asynchrony because the TA which the baby is needing and the TA what you have set on a ventilator might be different. So you can see the flow scalar and set the appropriate TA which is suitable for that baby to avoid this expiratory asynchrony and also the inspiratory flow. So here you can see here only as the set breaths are supported, the transpulmonary pressure is more only in certain areas, whereas in an SIPPV, in all the breaths, the transpulmonary pressure is high, thereby delivering a very uniform tidal volume. So in an acute stage, it is an excellent move of SIPPV. But if you just leave the baby on SIPPV, you have to be beware of hypocarbia, which is happening because sometimes it can get auto-triggered or it can inadvertently support all the breaths thereby causing hypocarbia. Especially if you are ventilating normal baby, you need to be beware, especially if the baby is in pain or discomfort, baby can breathe fast and it can lead on to hypocarbia. And a strict no for hypocarbia because it causes cerebral perfusion to go down and ischemic changes and later on PVL. So we tolerate hypercarbia very much, but not hypocarbia at any cost. So what are the issues? It can cause air trapping, especially the breathing rate is very fast and the baby is not having adequate time for expiration. As we discussed, there can be sometimes dangerous hypocarbia with normal lungs. And still expiratory asynchrony is a problem. So here, the cycling is controlled only by the machine because we are the one who sets the TA. So as we discussed earlier, what is the issue with SIMV as well as assist control? You can have an inspiratory hold. So what it says is, the baby is moving on to completed the inspiration and moving on to expiration, but the machine is still in inspiratory phase because you have set a specified TA can cause an inspiratory hold. How to avoid that? You can move on to more friendly, namely pressure support ventilation, which is PSV. So PSV is nothing but a flow cycled assist control. So it also supports all the breaths taken by the baby. For example, you have set a rate of 40, baby is breathing at a rate of 60. All the 60 breaths will be supported by PSV mode. But the cycling, which is changing from inspiration to expiration, is not time cycled, but it is flow cycling. What the machine does is, when the baby is changing over from inspiration to expiration, or when the inspiratory flow is getting reduced, it recognizes that and switches over from inspiration to expiration. So in your flow cycling, you set in what is known as termination sensitivity. So this is the flow graph. As the flow is keeping on reducing, before the flow touches 0, that means the baby has stopped inspiration and moving on to expiration. You can move on the baby from inspiration to expiration when you are in PSV. Say, for example, you have set a termination sensitivity at 15%. The ventilator cycles from inspiration to expiration when the flow reaches 15% of the peak. So this is the peak flow, which is 100%. This is the flow at 15%. So you can decide on the termination sensitivity. You can keep a 5% or 25%. Generally, it is set at 15%, the termination sensitivity. Many of the machines will not even ask for a termination sensitivity. It is fixed already at 15%. So here, what is the, this is a time cycle breath. So you can see that after the flow is getting completed and coming to the baseline, still the machine is in the inspiratory phase only. Here you are changing from time cycle to flow cycle breaths, where you have set a termination sensitivity of 15%. When the flow is reaching 15% of the peak flow, the machine automatically switches over from inspiration to expiration, thereby giving more hand to the baby. So the inspiration is also controlled by the baby because it is the trigger mechanism which identifies the baby's inspirations and starts the trigger. The expiration is also controlled by the baby because it is flow cycle. Only the peak pressure, whatever is delivered, is what you have. But beware, whenever you are putting on PSV, it is otherwise known as spontaneous mode. So you have to make sure that the baby's breathing effort is adequate. For example, you want to continue ventilation for one more day for some reason, you can put on PSV. It is more baby friendly because both inspiration and expiration is controlled by this, by the baby itself. Only the peak pressure is what we decide, and there is no fighting, and there is no asynchrony. However, what is the disadvantage is it can translate into your lower map. So PSV, it is, as I said, flow cycle. So sometimes the inspiration TI will be short, sometimes TI will be long, depending on how the baby is breathing. Sometimes if the baby tries to breathe very slowly, have a side breath, the TI will be long. So it is not a constant cycling which is happening here. It is depending on the baby's effort as such. So all breaths are supported. So it's otherwise known as the PSV functions as flow cycled assist control with backup rate. Simply remember as flow cycled assist control, that is enough. So it prevents expiratory is like it provides synchrony of expiration. So the variable I time is decided by the baby. So less fluctuations in the intrathoracic as well as intracranial pressure. However, what is the problem? As you saw earlier, the area under the curve might be less. So there could be sometimes lower map in acute stage and atelic cases. So sometimes if the flow cycling is not, or if there is a leak and the leak exceeds the threshold for inflation termination, you need to be beware that like you need to set a TA limit, which is 50% more than the baseline TA of the spontaneous breath. So again, how much the cycling, which is from inspiration to expiration, is also taken over by the baby here. Sometimes you might combine SIMV with PSV, though we do not do routinely in newborn. In pediatrics, they might be doing this. So SIMV provides support for fixed breath rate. Whenever there is a spontaneous breath in between, it is supported by PSV. So here, this is only SIMV breaths. Here, the spontaneous efforts are not supported by the machine. Here, you are adding some pressure support for those spontaneous effort so that all the breaths of the baby is supported to deliver a higher volume. So again, SIMV with PSV is also the baby is controlling the, that means from inspiration to expiration. So what is the evidence? We know that the assist control or SIMV is better than CMV because there is synchronization happening. When they compared assist control versus SIMV, there was shorter duration of weaning by 42 hours. But however, there is no reduction in BPD. What are the take homes? We learned about patient trigger modes. Basically, you need to know your baby for what condition you are ventilating, and you know the ventilator as well. And also, you need to monitor the tidal volume. You will learn in subsequent sessions how to target the tidal volume as such. So I would like to end with this quote. I fear not the man who has practiced 1,000 kicks once, but I fear the man who has practiced one kick 10,000 times. So I think you need to practice. Thank you for the opportunity, and the forum is open for questions if I can.
Yeah, thank you, Dr. Uma. Actually, it will be much easier now for us to make delegates understand when we have the ventilator during the workstations, and then we can show them how the SIMV works, and when we add a PSV, what effect does it make, or how the assist control works. So these conventional modes are being routinely used in NICU, and possibly I'll request all the delegates to read more about it. There are many books available uh, on ventilation, and this lecture is going to definitely help them understand what exactly is written in the book and what it means. And if they have any doubt, then we'll be there on the workstation to help them out. If there is any question, then we can take. Otherwise, we will see you all tomorrow same time. Any question? I can see in the chat box uh, value of triggers to be set. Dr. Uma, it is for you, value of
Yeah.
triggers to be set.
Dr. Alok Singh, there is no set value as such. You want to, support as much breaths as possible, especially in the acute state. So you need to know your machine. So there is something called as that itself will say like how much. See, basically you can have a flow or you can have a pressure. Majority is flow, so you need to set as lower flow as possible. What it means is when the baby is trying to take the breathing, once that particular flow difference, say for example, you are setting 0.1 liter, that is 100 ml. Like for example, 0.1 if you are setting, if there is a change of 0.1 itself, the machine will know that, okay, the baby is trying to trigger. So you need to set in as low flow as possible. So if you are increasing the flow, that means the baby has to take that much of flow to make the machine recognize that, okay, I am taking inspiration. So in a very small baby especially, we will try to keep the trigger in such a way that we give all babies all breaths are supported. We will try to handhold you during the workstation depending on the machine what we are using.
Yeah, so the trigger is going to be different in different ventilator. Their values are going to be different for different ventilator. So you should know what type of trigger you are using and what type of ventilator you are going to have. Just practice that only. That is good enough. You need not to know the trigger values for each and every ventilator. Whatever ventilator you are using, you should know the trigger value of that particular ventilator. Many ventilator will have lower values that will make them more sensitive, higher values make them more sensitive. So it may vary from different ventilator to ventilator. You need to understand the concept that whether you are going to make ventilator more sensitive or less sensitive for the baby.
Actually, also there is a question by Dr. Alok Singh. Tell
So
about alarm limits to set.
yeah, and it is going to be different for each and every baby. You want to make ventilator more sensitive for the baby to for it to detect the breath of a baby. On the other hand, you don't want to make it that sensitive that it should start auto triggering. So that is a balance between not auto triggering and not allowing the baby to work more hard.
Moving
Why
on.
SIV, PSV? Should I take? Are
Moving
you
on.
going
So
to
there is
take,
one
Dr.
more.
Uma? Yeah.
There is one more thing like alarm limits. So that's a very nice point which you have brought. I did not touch because like in 30 minutes you won't be able to cover the alarm setting. So definitely, depending on the condition, you need to keep your alarm limits. Now I would, if you are asking me what I ventilate is, we always move on to hybrid mode or volume guarantee. If at all a baby is needing ventilation, we are always putting on only volume guarantee. We do not actually put on standalone assist control or standalone SIMV. So the alarm limits again depends on what mode you will choose. And it should be, say for example, PWP means you can set a alarm limit of 8 if you are setting a PAP of PWP of 6. So again, PAP alarm limit, if depending on whether it is a volume guarantee or not, sometimes Pmax is nothing but the alarm limit which you set. So whatever is the working pressure, working PAP, 5 above, 3 to 5 above is what we will be setting in PAP. So again, I already told in PSB, so it should be 50% more than the spontaneous breath. So these should be your alarm limits. Definitely alarm limits is the one which we need to pay attention to. Just not come off the baby without setting the alarm. So why PSV, SAME with PSV not used as routine versus SAME in neonates? Generally in acute state, what we practice is assist control mode, but it is nothing that one mode is superior to another mode. Because of some of the inspiratory asynchrony possible in SIMV, in acute phase, we want to support all the breaths. So that is why instead of having SIMV and on top of it, you want some pressure support for spontaneous breaths. Instead, we can support all the spontaneous breath itself in first place. So,
Just adding on that, hardly nowadays the ventilator come with the plain SAMV. Almost all the ventilator have SAMV plus PSV load. And it is not used in neonates. No, it is being routinely used in neonates nowadays. We hardly use SAMV plain in neonates. It is the reverse. Yeah, I think we have finished the uh, anything, Dr. Uma? Last minute, Dr. Mayank? Any any last message you would like to give, or should we close the session?
So we can close, I think.
yes, sir,
Yeah,
we can close.
yeah. Okay, Doctor. Okay, thank you, Dr. Uma and Mayank, for your excellent presentation and very beautifully uh, spoken as well as presented. And thank you, delegates. I hope you have enjoyed these sessions, and we are going to see you tomorrow in the same time with the next two topics. Sarita, we are closing the session.
Okay, sir.
Yeah, Dr. Niranjan, anything you would like to add?
No, thank you very much, all the speakers. There was one little query that what is the clinical implication of effect of gravity on ventilation perfusion in newborn?
Dr.
Okay.
Mayank, would you like
Yes,
to
sir.
answer that? Yeah.
Okay, right. So, I've shown that the gravity causes basically the perfusion to increase in the dependent area. So now I had showed the image basically of an upright lung. Now, if we imagine that the baby is sleeping supine, so the dependent portion becomes the back, the part which is at the back. So in this case, the perfusion is better at the dependent areas, while ventilation is better in the non-dependent areas, that is the anterior part. So again, there's a ventilation mismatch. So there comes the benefit of prone positioning. So if we keep the baby prone, so some studies have that prone positioning in newborns have better VQ matching and therefore better oxygenation as well as CO2 washout. So one is prone positioning, and second, you would have observed that second clinical implication is that the babies with collapse, we usually tend to keep the babies with collapse on the collapse side over the normal side. So basically we try to keep the collapse part up. Now what does this do? This is it actually facilitates the secretions out from the trachea, but problem occurs here is that again what happens that uh, the dependent portion, which is the better part, basically if the better part which becomes the dependent portion now is at a disadvantage, the ventilation basically is poor, but the perfusion is better. So again, this might actually worsen the oxygenation in a collapsed lung. So if we put the collapsed lung up, then there might be a little bit more worsening clinically in oxygenation with this position. Compared it with in the opposite way, if we see that in a case of PIE, this would actually help. This would keeping the PIE on down would help the baby to have less ventilation in that part, and then the resolution of PIE. So basically, three implications. There are three implications: prone positioning. There would be slight deterioration if we keep the collapse part up, and there would be improvement in PIE if we keep the PIE part down.
Yeah, sometime in diaphragmatic hernia also it can help. The effect of gravity, you can take the advantage of effect of gravity in congenital diaphragmatic hernia if the ventilation is difficult in that scenarios. Okay, thank you, Dr. Mayank. Okay, thank you, Dr. Niranjan. Good night. See you all
Good night.
tomorrow, the same
Thank
time,
you. Thank
8:30.
you, everybody. Thank
Yeah.
you. Good night.
Right. Thank you.